Michelle, thank you for being here with me today.
Thanks for
We're going
having
to discuss PARP inhibitors and how that's transformed ovarian cancer care. And you're a great person to talk to because you've been on a PARP inhibitor, rucaparib, for treatment of ovarian cancer.
I've been on it since mid-June.
Which is a perfect opportunity to share your experience with all the oncologists that are considering treating their patients with PARP inhibitors.
Oh, PARP inhibitors is a dream come true for me. My first frontline with carboplatin, Taxol, and Avastin, I had a lot of really bad side effects from that first frontline. PARP inhibitors, I have very few side effects.
Right. So I believe that PARP inhibitors, their FDA approval and inclusion in the treatment of ovarian cancer has certainly been transformative. And where we are in the treatment landscape of ovarian cancer, before PARP inhibitors, we've had biologic therapies such as bevacizumab, but for the most part, it was really chemotherapy. And while these drugs do have side effects, they don't tend to be as severe as some of the chemotherapy side effects that we see. So I think it's an invaluable opportunity for you to share the stage with me and share your experience.
I'm doing great on this. The side effects for me, I have a little nausea once in a while, abdominal cramping once in the blue moon, sinasal drip, but other than that, and some fatigue, but other than that, I'm doing great on this.
So currently there's 3 PARP inhibitors that have been FDA approved. 2 of them for the treatment of recurrent ovarian cancer, and then 2 for maintenance therapy in women with platinum-sensitive ovarian cancer who respond to retreatment with platinum-based chemotherapy. So I'm just going to go through those a little bit. The 2 that have been approved for the treatment of recurrent ovarian cancer are olaparib, and that is approved for women who have either a germline BRCA1 or BRCA2 mutation and have had 3 prior lines of therapy.
Okay.
And then there's rucaparib, which is a PARP inhibitor that is approved for women with recurrent ovarian cancer who've had 2 prior chemotherapies and have either the germline mutation or a somatic mutation. That means a mutation just in the tumor, but they didn't inherit it from a parent. And then we have the maintenance situation, which is a little different because the PARP inhibitors that approved there, olaparib and niraparib, and I think soon we'll have see an approval for rucaparib in that space as well.
Oh, interesting. Okay.
Right, just based on a new study that was released called Ariel 3, and that was recently published, showing that similar to the other PARP inhibitors, rucaparib also prolonged disease control in women who had platinum-sensitive cancer who had either a complete response or partial response to platinum-based therapy. So it does get confusing, but in that space, it's all comers. So women don't have to have the mutation in BRCA1 or 2 to be able to get these drugs.
Oh, I didn't know that. Okay.
It's very interesting. And so one of the first drugs that was evaluated was niraparib on the NOVA trial. So women who had platinum-sensitive ovarian cancer, who had a complete response or partial response to therapy, could go on this study. And then there was 2 groups. There was one group that had the germline mutation, and then the other group had did not have the germline mutation, or the non-germline cohort. So they're called cohorts, right? And they found that in the entire group overall, there was a benefit to PARP inhibitor therapy in terms of prolonging disease control. And that the greatest benefit was actually seen in the women who had a germline mutation in BRCA1 or BRCA2, and that benefit was like 21 months versus 5 months, which is, I see your face.
I'm thinking 21 or 5, Yeah,
no brainer there.
That's a no-brainer, I'll take the 21.
And so what was surprising too is people have this idea, these patients, they're all platinum sensitive, they're going to do so great on chemo anyway, but 5 months doesn't seem like done so great on chemo, right? And then also, you have a BRCA1 mutation. When you got retreated with platinum-based therapy, you didn't have a complete response. You had a good response,
but not
it was
complete.
A partial response.
Not what we were hoping.
So I think sometimes the reality isn't always what we remember.
I agree.
So going back to this study, when they further divvied up these groups, they saw benefit in the non-germline cohort as well, but it wasn't quite as strong. But it was still, significant reduction in risk of disease progression, so meaning better disease control. I think it was about 60% better disease control in that group.
Wow, okay.
And then they further broke that down, stay with me, because this is confusing.
It's very confusing, but I'm here.
Into patients who had a tumor that had positive HRD, which is homologous recombination defect, and that was based on a special test they do. It's a myriad test, and it uses a certain score. So if they scored greater than 42, they were said to be HRD positive. And so in that group, again, they showed this benefit, as well as patients who had the tumor BRCA mutations that weren't inherited. And they even showed a benefit in the patients who were completely biomarker negative. So didn't have a germline mutation, didn't have HRD, and they demonstrated a disease control benefit about 3 months, which isn't as, your face is so different.
I know, but 3 months, that's better than nothing.
Right, but you're like, when I said the first one with the BRCA, you're like, I saw you light up. And then, so the negative it's not quite as strong.
It's not.
So that's where it's sometimes difficult in terms of making a decision, because you're on bevacizumab, which also has about a 3-month disease control rate. So trying to decide between those two in that biomarker population can be challenging. So that was the niraparib trial. So because they saw that benefit in all comers, the FDA approved it for all patients. You don't have to have a
mutation.
A test. Right, you don't have to have a mutation, you don't have to have a defect. You don't need to have a test to show that there's a mutation or HRD positive tumor to be able to give the patient the drug. So that was that test. Now the olaparib study, there was 2. Study 19 was the first study that showed a benefit of these maintenance treatments. So in that study, it was all comers, but it was a small phase 2 trial. And again, with olaparib, they showed improved disease control in the entire group with using the maintenance PARP inhibitor. And again, it was in patients with platinum-sensitive disease who had either a complete response or partial response to platinum therapy. What's interesting is that study probably wasn't large enough to get the support it needed to move to get FDA approval. So then they followed it up with another study, and they followed it up specifically only in the study design was only for women who had a germline BRCA1 or 2 mutation, and that's because in that group they found this ridiculous improvement in progression-free survival. I mean, it was amazing. They were able to control disease, reducing the risk of disease progression by 80%.
Wow.
Again, a big wow.
That's really good news.
Right.
Yeah.
So then the Solo 2 trial, they limited it to this population where they saw the biggest benefit. And again, they saw this whopping improvement in progression-free survival. So that was approved by the FDA, not just for that select group that they studied, but for all comers.
Wow.
Based in part, I think, on the study 19, the smaller study, but also probably from the NOVA information as well. So that's how we have those 2 studies there.